Hi, my name is Jennifer Woyach. I'm a professor at The Ohio State University where I lead the CLL program. I'm excited to talk with you today about chronic lymphocytic leukemia, or CLL, and small lymphocytic lymphoma, or SLL. During the course of this talk, we'll discuss the biology and natural history of CLL. We'll discuss criteria for the initiation of treatment for this disease, as well as discussing some specific therapies for CLL. So first, I just wanted to start with a little refresher of where does CLL come from. This might be a review for some of you, but as you know, the bone marrow is where all of the blood cells are produced. Initially, hematopoietic stem cells, here noted as blood stem cells, are formed. And these cells will differentiate into myeloid stem cells, which eventually give rise to things like red blood cells, platelets, neutrophils. And then the other side of this is the lymphoid stem cells. And these differentiate primarily into B lymphocytes, T lymphocytes, and natural killer cells. In CLL, a mutation arises somewhere in this process, and it's still a little bit debated whether this is at the blood stem cell level or at the more mature kind of B cell differentiated level, which changes this kind of normal process of hematopoiesis into a cancer. And in this case, it's a cancer of these B lymphocytes where they begin to acquire signals to tell themselves to continue to grow and to divide. CLL is often considered to be a disorder of disordered apoptosis. So apoptosis is a way that cells will normally cause their own death once they've completed their assigned purpose. In all cancers, cells don't die. And in CLL, because the cells don't actually grow so quickly, it's considered mostly to be a problem, just that the cells are immortal. And so these cells will eventually accumulate in lymph nodes, blood, spleen, and bone marrow. And these cause all of the symptoms that we see in CLL. And it can cause things like enlarged lymph nodes, which can become uncomfortable. It can cause the spleen to become enlarged. It can cause the normal blood cell production to go down if the bone marrow is so full of CLL cells. CLL cells also disrupt normal immune cells because they're very immunosuppressive. So the CLL cells will secrete inflammatory proteins called cytokines, which actually make other blood cells not work the way they're supposed to. So you also have likely heard the term SLL, or small lymphocytic lymphoma. And this is considered to be the lymphoma version of CLL, and it's actually the same disease. It was initially thought to be two separate diseases, so a disease of B cells in the blood and a disease of B cells in the lymph nodes. Now it's become recognized that really, under the microscope, these cells look the same. When you look at genetic abnormalities of the cells, they're all the same. Prognosis is the same, outcomes are the same with treatment. So we generally kind of consider them together, CLL and SLL. But the specific definition of it is that CLL requires 5,000 of these cancerous B cells per microliter of blood. And if that threshold isn't met, but the person has enlarged lymph nodes, we call that SLL, or small lymphocytic lymphoma. For people who actually have less than that 5,000 CLL-like cells per microliter and don't have any enlarged lymph nodes, we call that monoclonal B lymphocytosis, or MBL. And this is actually considered a pre-malignant condition, so it's not a cancer. So just looking a little bit at the natural history of CLL, this is actually the most prevalent leukemia. There's about 15,000 cases diagnosed per year, which is not a large number. But since people tend to live for a very long time, that's how it becomes the most prevalent leukemia. It's considered primarily a disease of older adults with a median age at diagnosis somewhere between 70 and 72. There certainly are younger patients who are diagnosed with this disease. It's a little bit more predominant in males than females, especially in younger people. As people get older, it actually becomes 1-to-1 about age 80. People who are Caucasian have a higher incidence than African Americans, which is a much higher incidence than those who are from Asia. There's about 4,500 deaths per year due to CLL, and this is actually decreasing pretty much every year. The absolute survival has increased pretty dramatically over the past two decades and is still continuing to increase. So CLL is a very heterogeneous disease. And so some people will be diagnosed with CLL, will spend the rest of their life just being monitored without any treatment and will die of something else. Other people might need treatment relatively close to the time they're diagnosed and may need multiple treatments during the course of their lifetime. We have a number, though, of prognostic studies, which can be very helpful to understand whether somebody is, at the time of diagnosis, is more likely to be someone who goes for years and years without treatment or somebody who's going to need treatment more quickly. The ones that are commonly used, we have a few clinical factors, and this includes stage. So that is, where is the disease located? We can look at something called lymphocyte doubling time, which is just what it sounds like, whether or not the lymphocyte count in the blood doubles over the course of a year or not. Beta-2 microglobulin is a protein that can be secreted by CLL cells, and elevated levels of beta-2 microglobulin increase or mean a more aggressive disease. And then there's a number of studies that are related to the genetic risk of the CLL that are very important. I actually don't have a lot of further slides on these, so it says will be discussed later, but the IGHV mutational status is a way to categorize CLL into kind of low risk, which is called IGHV mutated. And these types of CLLs look like more mature B cells, and they tend to be slow growing. And then IGHV unmutated, where the CLL cells more resemble immature B lymphocytes, and those tend to be more aggressive. FISH testing and stimulated karyotype is looking at the chromosomes of the CLL cells, and different chromosomal abnormalities are highly linked to specific prognoses. And then the presence or absence of a mutation in a gene called TP53, which is a tumor suppressor protein. Basically, in all cancers, and CLL is no exception, people who have a mutation in this TP53 gene tend to have a more aggressive disease. So one thing that is really important is whether prognosis can change over time. So a lot of times we'll check prognostic status at the time of the patient's diagnosis, and then do you need to actually repeat these things? So the IGHV mutational status, that's what I discussed, kind of split CLL into two groups: mutated, which is more slow growing; unmutated, which is more fast growing. That does not change over time, so never needs to be repeated. CLL cells, though, during the course of a disease, and especially when exposed to treatment, can develop new mutations in the DNA or new abnormalities in the chromosomes as the cells divide. That's a process that's called clonal evolution. And it's really important in CLL, and we see that both, in changing people's prognosis over time to make the cells, easier to get around therapy and more aggressive, but also in response to specific therapies, cells can acquire new gene mutations that might make them resistant to a treatment. And kind of as an example of this, TP53 abnormalities, so mutations, are seen in about 10% of people at baseline. But when you're looking at people who have had multiple prior therapies for their CLL, it gets up to about 40%. And so this schematic kind of just outlines the way a process like this occurs. So, we think that CLL likely starts with one cell that it becomes a cancer cell and then makes additional copies of itself. A mutation can arise, which makes a certain type of cell here, this light red one, have a different mutation in it that allows it to survive in addition to the other ones that are there. Another mutation might create this purple cell type right here. And then you get a treatment. And after a treatment, it might affect those different cell types differently. But if you kind of assume that you end up with the same amount of all three of those cells with different mutations, you could either find that one of these clones, we call them, outgrows the other and just gets back to a completely homogeneous group of cells. You can have all three of those different types of groups expand, and maybe some grow faster than others, so their proportion is different. And then you also could have just one of the clone types disappear. And in this case, it's the original one. And then the other two can grow out. And so you can see there's really varying ways that the CLL can change and adapt to treatments and even just to kind of random genetic mutations. So right now, we treat CLL only at the time that symptoms develop. And I'll tell you why in just a minute, but here are some of the reasons for initiating therapy in CLL. And so one of these categories would be symptoms related to the disease. And we call these usually constitutional or whole body symptoms. These are things like night sweats, weight loss, fatigue. We also would treat for symptomatic increases in tumor burden. So here we have progressive lymph node enlargement, progressive spleen enlargement, and what the spleen is located on the left side of the abdomen. And if that gets very big, it can push against the stomach and make people get full very quickly. If the enlarged lymph nodes are kind of obstructing an organ or, obstructing something that's is causing symptoms, that's another reason to start treatment. If the CLL cells fill up the bone marrow so much that you can't make red blood cells and become anemic or can't make platelets and the platelet count becomes low, those are reasons to start treatment too. And then as well, people can develop what are called autoimmune complications from their CLL. And if we can't treat those things with standard therapy, it's a time that we would initiate treatment for the CLL. So why don't we treat at diagnosis? There's been actually a number of clinical trials that have investigated this question, and none yet have shown a survival advantage to early treatment. But as our treatments get better and better for CLL, and especially as they get better and better tolerated, this question kind of remains of interest. And there is a current national clinical trial. It's called SWOG 1925, which is a study of a combination therapy called venetoclax plus obinutuzumab, where they're taking patients who have higher risk CLL at diagnosis and randomizing them to early versus delayed therapy. Again, to answer this question, could early intervention make people with CLL live longer? So the natural history of CLL has changed dramatically over the past decade or so. And a lot of that has been because of advances in therapy. And really, the advances in therapy have been, instead of treating people with chemotherapy, we now use targeted therapies. I listed a few of the therapies that can be used in the frontline setting. And, the ones that predominate right now and should predominate are two inhibitors of proteins called Bruton's tyrosine kinase, or BTK, acalabrutinib and zanubrutinib. And acalabrutinib can be given with or without an antibody called obinutuzumab. And then a combination called venetoclax plus obinutuzumab. We'll talk about this a little bit more. So starting with these Bruton's tyrosine kinase, or BTK inhibitors, and again, these drugs, the ones that are currently FDA approved, are ibrutinib, acalabrutinib, and zanubrutinib. This schematic for you might look like something that you saw back in biochemistry class one day. But it's the signaling pathway that can occur that does occur inside CLL B cells. And this signaling pathway activity of this pathway is what leads to the CLL cells being cancer cells. So it makes them continue to divide, it makes them stick inside the lymph nodes, makes them release inflammatory proteins that make people not feel so good. When you block that signaling with these types of drugs, it's like turning off a light switch to the CLL cells, and the signaling stops and the cells disengage from the lymph nodes, the cells stop producing these inflammatory proteins, and eventually they will die. These three drugs listed here, ibrutinib, acalabrutinib, and zanubrutinib, are what are known as covalent inhibitors. So they irreversibly inhibit BTK. They all have exactly the same mechanism. So you can't kind of sequence them. You can't first use acalabrutinib, and then if it stops working, use zanubrutinib. You have to choose one and go with it. The other standard therapy that we primarily use is a drug called venetoclax, which is what's known as a anti-apoptotic targeting drug. So it inhibits a protein that's called BCL2, and BCL2 is produced by CLL cells and other cancer cells as a mechanism to keep themselves alive. And so when venetoclax goes in there and blocks BCL2, the cancer cell will die. We give venetoclax in combination with an antibody treatment called obinutuzumab. So obinutuzumab is given through an IV, venetoclax is a pill, and obinutuzumab will target cells that express a protein called CD20 on their surface, which includes CLL cells. So how do we choose therapy? So the first consideration, and one that I think has been put to rest now, is targeted therapy versus chemoimmunotherapy. Multiple clinical trials now, head-to-head studies of targeted therapy versus chemotherapy, has shown over and over and over again that targeted therapies are more effective than chemotherapy. So the only people who really should be considered for chemotherapy at this time are some patients with very low risk CLL, those IGHV mutated patients who are young and otherwise fit. Some of them might actually be cured by a chemoimmunotherapy regimen called FCR, fludarabine, cyclophosphamide, and rituximab. But there are long-term side effects to this regimen. And I think, even in this group of people, targeted therapies are probably better, in my opinion. So next consideration is, how do you choose between the targeted therapies? So I mentioned in the class of BTK inhibitors, there's three. There's ibrutinib, there's acalabrutinib, and zanubrutinib. And then you also have that whole class versus the venetoclax drug I mentioned. Now, I'm going to encompass, a decade of research in 2 slides. And so there are going to be some details missed, but basically when we're thinking about the BTK inhibitors, there have actually been now head-to-head studies among a couple of them. So acalabrutinib, which is a second generation BTK inhibitor, has been compared with ibrutinib. Zanubrutinib, which is another second generation BTK inhibitor, has also been compared to ibrutinib. In the head-to-head trial of acalabrutinib versus ibrutinib, the two drugs are similarly effective. In the head-to-head trial of zanubrutinib to ibrutinib, zanubrutinib was actually more effective than ibrutinib. It is unclear. So these were actually done in relapsed refractory CLL. So it's not entirely clear that this, superiority of zanubrutinib to ibrutinib translates to the frontline setting. But what definitely translates to the frontline setting is the side effect profile that we see. And in those head-to-head studies, both acalabrutinib and zanubrutinib were safer than ibrutinib. And primarily, they were safer due to decrease in cardiac events. So people can actually have heart rhythm disturbances, primarily atrial fibrillation from ibrutinib. And this can also be seen with acalabrutinib and zanubrutinib, but the rates are significantly less. Ibrutinib also can cause high blood pressure or hypertension, and acalabrutinib seems to have quite a bit lower rate of hypertension than ibrutinib does. There also was a trial that has looked at actually both acalabrutinib by itself and in combination with that CD20 obinutuzumab. And for some people, actually, that combination might be a better way to go than just acalabrutinib by itself. So, we have 3 drugs in this class. Acalabrutinib and zanubrutinib are the preferred agents because of their safety. And between the two, it's hard to say that one is actually better than the other in terms of its efficacy, really, or safety. There's a few differential side effects with the different drugs that might be taken into consideration for specific people. So acalabrutinib can cause headaches. Zanubrutinib seems to have a little bit higher rate of neutropenia, which is lowering of the good white blood cell count. Also might have a little bit higher rate of the hypertension. So overall, acalabrutinib and zanubrutinib are the preferred options. And then how do you choose between a BTK inhibitor and venetoclax obinutuzumab? Again, summarizing a lot of research in a very short period of time. For people who have really high risk CLL, and that specifically would be those people with TP53 mutations or a certain chromosome abnormality called a 17p deletion, it seems that continuous therapy, and here we do that with a BTK inhibitor, might be the best approach. On the converse, people who have very low risk CLL, and again, those are going to be those IGHV mutated patients, are likely going to have a really long remission with any treatment. And so for these people, venetoclax plus obinutuzumab might be the best approach because this is actually a fixed duration therapy. So BTK inhibitors like ibrutinib, acalabrutinib, and zanubrutinib are started and then can be taken for many years. And we plan on giving them until either they stop working or somebody has a side effect that makes them not able to tolerate it anymore. In contrast, venetoclax obinutuzumab is given for 1 year and then stopped. So for these people who have very low risk CLL, they're likely to get a really long remission duration after just 1 year of treatment, and that is probably the best approach for them. For most patients, though, there isn't a right answer, and preference between a fixed duration or a continuous therapy and a frequency of visits and side effect profile might help decide. Couple of other considerations that I just want to bring up. In addition to treatment, we really have to think about the complications that CLL has on the immune system. And I mentioned that the CLL cells will secrete proteins that make other immune cells not work very well. And so that can lead to a higher incidence of infections, actually autoimmune disease, and other cancers too. And in one study with a large number of people, you can see that risk of infection, other cancers, and autoimmune diseases over 20 years is actually very high for people with CLL. And because our treatment for the disease is so effective and survival from CLL is very good, these other things can be an important cause of morbidity and even cause people's deaths. And so vaccines are important and recommended. As well, I mentioned second cancers or other cancers are higher in people who have CLL. Um, Basically, any type of cancer that's common is likely to be a little more common in the setting of CLL. The kind of highest differential between people without CLL and people with CLL comes with skin cancers, things like squamous cell carcinoma, basal cell carcinoma 2, Merkel cell carcinoma, which is a really rare skin type cancer, and then a non-Hodgkin's lymphoma, an aggressive lymphoma called Richter's syndrome. And because of this, routine cancer screening is important, including dermatologic exams, which we recommend yearly. So to conclude, CLL is a cancer that includes the blood, the bone marrow, lymph nodes, and spleen. Currently, there's no advantage to treating CLL early, but when it does come time for therapy, there's many non-chemotherapy options. And as our CLL therapy gets better, other supportive care issues like infection prevention and secondary cancer screening becomes even more appropriate. I want to last leave you with a recommendation to ask your doctor about clinical trials, especially if you are in need of therapy. If your doctor doesn't have clinical trials, maybe you look out and see whether there is a place that does do clinical trials that you might find other options for the treatment of CLL, because this is really how we've made so much progress in CLL and how we're going to make the next big leaps in CLL therapy. Thank you very much.